Welcome to ClinMed Compass. I am Dr. Emorike, and today we'll be discussing hypoglycemia, its diagnosis, pathophysiology, and management. This lecture is tailored for medical students, resident doctors, and anyone keen on mastering this important topic in internal medicine. Before we dive in, don't forget to subscribe to ClinMed Compass, hit the like button, and turn on the notification bell so you never miss our high-yield internal medicine lectures. By the end of this lecture, you should be able to define hypoglycemia and classify its severity, understand the physiology of glucose homeostasis and the counter-regulatory mechanisms, recognize the clinical features, apply a structured diagnostic approach, manage acute and recurrent hypoglycemia effectively, and finally, integrate recent advances in monitoring and treatment. Keep these objectives in mind as we go through the session. Hypoglycemia is a clinical syndrome characterized by a low plasma glucose concentration to a level that may induce neuroglycopenic or autonomic symptoms. It is the most common endocrine emergency and represents a major barrier in achieving optimal diabetes management. Importantly, hypoglycemia is not limited to diabetes. It can also occur in non-diabetic individuals. If left untreated, severe hypoglycemia can lead to seizures, irreversible brain damage, cardiovascular events, and even death. Understanding this condition is therefore crucial for both the clinician and the patient. Hypoglycemia is defined as a plasma glucose level of less than 70 milligrams per deciliter or 3.9 millimoles per liter. Several important terms are worth noting. Severe hypoglycemia. This refers to any episode of hypoglycemia that requires external assistance, irrespective of the measured glucose level. Recurrent hypoglycemia. This is defined as 2 or more episodes of hypoglycemia within 3 months. Hypoglycemic unawareness. This occurs when there are no adrenergic warning symptoms, despite a very low glucose level. Finally, remember to interpret values in context. Patients accustomed to chronic hyperglycemia may experience symptoms even at glucose level around 90 milligrams per deciliter. The American Diabetes Association categorizes hypoglycemia based on severity into level 1, 2, and 3. In level 1, the plasma glucose is below 70 milligrams per deciliter but above 54 milligrams per deciliter. This is the early warning level. In level 2, plasma glucose is below 54 milligrams per deciliter and it is considered clinically significant. This is the level for the neuroglycopenic threshold. In level 3, this is any hypoglycemic event associated with altered mental status or physical functioning that requires external assistance irrespective of the glucose level. Understanding these levels guides both clinical management and patient education. Hypoglycemia is common among diabetic patients, but can also occur in non-diabetic individuals. In diabetes, the United Kingdom Prospective Diabetic Study reported an annual incidence of severe hypoglycemia of 0.7 to 1.8%. The Diabetes Control and Complication Study found out that 65% of patients with type 1 diabetes reported at least one severe episode. Up to 90% of type 1 diabetes patients experience hypoglycemia yearly. Non-diabetic hypoglycemia is less common, but clinically significant, seen in conditions like insulinomas, alcohol-related hypoglycemia, and sepsis. The high-risk group for hypoglycemia are the elderly, neonates and infants, pregnant women, malnourished individuals, alcoholics, and patients that are critically ill. Causes of hypoglycemia. We'll classify these into causes in diabetic patients and causes in non-diabetic patients. In diabetic patients, hypoglycemia often results from treatment-related causes, including excessive insulin administration, sulfonylurea or meglitine overdose, missed or delayed meals, increased physical activity without dose adjustments, alcohol intake, especially without food. Causes of hypoglycemia in non-diabetic patients could be insulin-dependent and non-insulin dependent causes. Insulin-dependent hypoglycemia can occur due to endogenous hyperinsulinism, including insulinomans, islet cell hyperplasia like in nesidioblastosis, non-beta cell tumors that secrete insulin-like growth factors post-bariatric surgery. Exogenous hyperinsulinism is seen in surreptitious insulin administration as in factitious hypoglycemia, sulfonylurea or meglitine injection, which could be accidental, intentional, or even surreptitious. Then autoimmune hypoglycemia caused by anti-insulin antibodies. Other causes of non-diabetic hypoglycemia are non-insulin dependent, and they include medications. A variety of medications are implicated. It could be insulin, oral hypoglycemic agents, quinine, pentamidine, aspirin poisoning, ACE inhibitors, beta blockers, aminoglutamate, salicylates, and so on. Critical illnesses like sepsis, hepatic failure, cardiac failure, renal failure may have been implicated. Alcohol-induced hypoglycemia. This arises as a result of impaired hepatic gluconeogenesis and endocrine deficiencies like adrenal deficiencies and hypopituitarism. Other causes include non-islet cell tumors that secrete insulin-like growth factors, commonly seen in fibrosarcomas and hemangiopericystoma. Inherited metabolic disorders such as glycogen storage diseases, reactive or postprandial hypoglycemia, and prolonged fasting or malnutrition. This is an easy mnemonic to remember the main causes of hypoglycemia. Explain. EX, exogenous drugs, all the drugs we've listed before. Pituitary insufficiency. L for liver failure. A for Addison's disease. I for islet cell tumors. N for non-pancreatic neoplasms. We'll be looking at classification of hypoglycemia. We have the fasting hypoglycemia. This occurs after prolonged fasting greater than 8 hours. And common causes are insulinoma, non-islet cell tumor, liver diseases, and so on. You have the postprandial or reactive hypoglycemia. Occurs within 2 to 5 hours after meals. Common causes include post-gastric bypass as in dumping syndrome. Then we have the factitious hypoglycemia. This is basically self-induced as in Murchison syndrome. Hypoglycemia can be classified based on the underlying mechanism into two main categories. First, you have the hyperinsulinemic hypoglycemia. This occurs when there is excessive insulin action. Causes include exogenous insulin administration, endogenous insulin overproduction, such as in conditions like insulinoma, drug-induced hyperinsulinism, especially with sulfonylureas. Two, you have the hypoinsulinemic hypoglycemia. Here, there is inadequate insulin secretion, but glucose levels still drop due to other mechanisms. Causes include alcohol-induced hypoglycemia, critical illnesses such as sepsis, liver failure, or prolonged starvation, endocrine deficiencies, particularly adrenal insufficiency as in Addison's disease. Understanding the mechanism is crucial because it guides investigation and management. To understand hypoglycemia, we must first revisit normal glucose homeostasis. Under physiological conditions, fasting plasma glucose is maintained within a narrow range, typically 70 to 110 milligrams per deciliter. The body achieves this balance through three key processes. 1. Glucose intake, primarily from dietary carbohydrates. 2. Hepatic glucose production through glycogenolysis and gluconeogenesis. 3. Peripheral glucose utilization by tissues such as brain, skeletal muscle, and adipose tissue. Disruption of any of these processes can predispose an individual to hypoglycemia. The brain plays a central role in understanding the dangers of hypoglycemia. The brain requires approximately 120 grams of glucose daily to function optimally. Unlike other organs, the brain has no significant energy stores and cannot utilize fatty acids effectively. So as a result, the brain is highly dependent on a continuous supply of glucose. This explains why prolonged or severe hypoglycemia can lead to irreversible neurological injury or even death if not promptly corrected. The key hormones involved in glucose homeostasis include insulin, glucagon, catecholamines, cortisol, and growth hormone. Insulin effect will result in reduced glucose production, while the glucagon, catecholamine, cortisol, and growth hormone are referred to as counter-regulatory hormones, and they result in increased glucose production through various mechanisms. Maintaining glucose balance involves complex interaction between several counter-regulatory hormones. So when plasma glucose falls, the body will respond first by decreasing insulin secretion. This is the first line of defense and it helps to maintain the glucose level. There is also stimulation of the counter-regulatory hormones like glucagon, epinephrine, cortisol, and growth hormone. All these will cause increased glucose production to also maintain the glucose level through various mechanisms of glycogenolysis and gluconeogenesis. Additionally, the behavioral response of hunger and food seeking is also triggered to restore glucose level. When these mechanisms fail, then severe hypoglycemia can develop. So summarily, hypoglycemia occurs when glucose utilization exceeds glucose availability. And the major mechanisms include 1. Decreased glucose production, as seen in prolonged fasting, malnutrition, or hepatic failure. 2. Excessive glucose utilization, commonly due to hyperinsulinism, sepsis, or strenuous exercise. 3. Excessive insulin action from exogenous insulin therapy, sulfonylurea use, or insulin-secreting tumors. 4. Impaired counter-regulation, seen in conditions like hypoglycemia-associated autonomic failure. And 5. Alcohol-induced inhibition of gluconeogenesis, especially during fasting, leading to precipitous drop of the glucose level. Briefly on hypoglycemia-associated autonomic failure. It is a maladaptive condition in which recurrent hypoglycemia leads to blunted adrenergic warning signs and impaired counter-regulatory responses. It is most commonly seen in long-standing type 1 diabetes mellitus, advanced type 2 diabetes on insulin, patients with autonomic neuropathy, and the elderly. In type 1 diabetes, its prevalence can reach up to 50% after 25 years of disease, while in insulin-treated type 2 diabetes, it is seen in approximately 10% of patients. In hypoglycemia-associated autonomic failure, recurrent hypoglycemia progressively resets the brain's glucose sensing threshold. This results in delayed counter-regulatory responses, which are reduced activation of the sympathoadrenal system, leading to decreased epinephrine and non-epinephrine release, reduced glucagon secretion from the pancreatic alpha cells. All these result in blunted perception of hypoglycemic symptoms. Ultimately, this places patients at a markedly increased risk of severe hypoglycemia. Management strategies include strict avoidance of hypoglycemia for about 2 to 3 weeks, patient education, and the use of continuous glucose monitoring with predictive alerts. Clinical features of hypoglycemia. The symptoms of hypoglycemia can be grouped into autonomic and neuroglycopenic. Let us let us begin with the autonomic symptoms, which results from sympathetic activation. They could be adrenergic or cholinergic. Adrenergic symptoms include palpitations, tremors, anxiety, dizziness. Cholinergic symptoms include diaphoresis, hunger, paresthesia. 2. Neuroglycopenic symptoms. This results from direct glucose deprivation to the brain. They include confusion, irritability, drowsiness, dizziness, slurred speech, blurred vision, seizures, focal neurologic deficits, then coma. These symptoms actually manifest at glucose level at about 54 milligrams per deciliters. Then we have the atypical symptoms, which include personality changes, nightmares, nocturnal enuresis, mutism. Some patients may present with some peculiar manifestations. In the elderly, hypoglycemia may cause confusion, recurrent falls, or even stroke-like presentations. In children, seizures are a common manifestation. In long-standing diabetics, hypoglycemia unawareness is frequent due to autonomic dysfunction. Nocturnal hypoglycemia may present with nightmares, restless sleep, and morning headaches. The diagnosis of clinically significant hypoglycemia is based on the gold standard known as Whipple's triad. This requires 3 key elements. The first, symptom consistent with hypoglycemia, either autonomic or neuroglycopenic. The second, documented low plasma glucose, typically less than 70 milligrams per deciliter. And the third, resolution of symptoms after glucose administration. Key investigations include blood glucose to confirm hypoglycemia, either capillary or plasma blood glucose. Serum insulin and C-peptide helps to differentiate between endogenous and exogenous insulin sources. If we have increased C-peptide in the presence of increased insulin level, it suggests an endogenous source of insulin. Beta-hydroxybutyrate levels is suppressed in hyperinsulinemic states. Sulfonylurea screening is important in suspected factitious hypoglycemia. Cortisol and growth hormone levels are useful for detecting endocrine deficiencies. Electrolytes, renal function tests, and liver function tests. This helps to evaluate multi-organ involvement. A structured approach prevents unnecessary testing while improving diagnostic accuracy. Further investigations may be required depending on suspected cause of hypoglycemia. CT or MRI of the pancreas for suspected insulinoma. Endoscopic ultrasound or octreotide scanning for better localizations of small tumors like insulinoma. Some specialized diagnostic tests. The 72-hour supervised fasting test is important for suspected insulinoma and is a good standard for fasting hypoglycemia. Mixed meal tolerance test or the oral glucose tolerance test is useful in postprandial or reactive hypoglycemia. Prolonged oral glucose tolerance test may reveal an exaggerated insulin response in certain patients. This table summarizes some biochemical pattern in hypoglycemia. Increase C-peptide and increase insulin levels. Consider insulinoma and other causes of endogenous hyperinsulinism. Increase insulin level and reduce C-peptide. Consider exogenous insulin administration, perhaps factitious hypoglycemia. In reduced insulin levels and reduced C-peptide, consider critical illnesses, fasting, alcohol, non-islet cell tumor, amongst others. When there is reduced insulin levels and reduced ketone levels, consider alcohol-induced hypoglycemia, non-pancreatic tumors, autoimmune hypoglycemia. When there is reduced insulin and increased ketone, consider prolonged fasting or starvation. Reduce cortisol and reduce glucose, consider endocrine deficiency like adrenal insufficiency. Management of hypoglycemia depends on three factors: the severity of the episode, level of consciousness of the patient, and underlying cause. The primary goals of management are: 1. Rapid correction of hypoglycemia to prevent neurological injury. 2. Prevention of recurrence through careful evaluation and monitoring. 3. Treatment of the underlying cause to minimize future risk. So we look at the acute management of hypoglycemia. In conscious patients, follow the 15-15 rule. Administer 15 grams of fast-acting oral carbohydrates like glucose tablets, half cup of juice, regular sugar. Wait for 15 minutes, then recheck blood glucose level. If the glucose level is below 70 milligrams per dl, repeat the process. Once euglycemia is restored, provide a longer-acting carbohydrate snack or meal to prevent rebound hypoglycemia. This simple rule is highly effective and should be taught to all patients at risk of hypoglycemia. For unconscious patients or those experiencing seizures, administer intravenous bolus of 50 ml of 50% dextrose water. If recurrent hypoglycemia is likely, follow up with continuous infusion of 5% dextrose water. However, if IV access is unavailable, then there is room for giving intramuscular or subcutaneous glucagon 1 mg. Repeat in 15 minutes if there is no response. Important considerations include: glucagon is less effective in patients with alcohol intoxication or liver disease. Always ensure airway protection in unconscious patients. Once the patient regains consciousness, administer oral carbohydrates to replenish glycogen stores. Sulfonylurea-induced hypoglycemia is particularly challenging because it is often prolonged and recurrent, lasting up to 36 hours. Glucagon is usually ineffective. Octreotide is useful in its management because it suppresses insulin secretion. In alcohol-induced hypoglycemia, treat with glucose and thiamine. Avoid insulin in these patients as it exacerbates hypoglycemia. Long-term management and prevention. Managing hypoglycemia in the long term involves not just treating the acute episodes of hypoglycemia, but also trying to prevent recurrence. The first is you treat the underlying cause, like surgical resection of insulinomas where appropriate, stopping or adjusting the offending medications such as sulfonylureas or insulin, whichever is implicated, managing associated endocrine or systemic disorders such as adrenal insufficiency or hepatic dysfunction. 2. Patient education. Teach patients to recognize early warning signs of hypoglycemia. Encourage them to always carry fast-acting carbohydrates. Recommend wearing medical identification bracelets, especially for those at high risk. Medication adjustments. Avoid using sulfonylureas in elderly or hypoglycemia-prone patients. Preferred agents with lower hypoglycemia risk, such as dipeptidase 4 inhibitors, glucagon-like peptide 1 receptor agonists, then sodium glucose transporter 2 inhibitors. Adjust insulin doses based on meal patterns, physical activity, and comorbidities. Lifestyle modification is a factor. Schedule regular meals and carbohydrate counting. Avoid excessive alcohol intake. Adjust insulin appropriately before exercise to reduce hypoglycemic risk. Individualize glycemic targets. In young and healthy patients, tighter glucose control may be very appropriate. However, in elderly patients or those with multiple comorbidities or hypoglycemic unawareness, adopt a more relaxed glycemic target to improve safety. And finally, technology-assisted care. The use of continuous glucose monitoring devices to detect falling glucose early. Consider insulin pump therapy for patients with recurrent episodes of hypoglycemia. Recommend emergency glucagon kits for high-risk individuals and train patients and caregivers on their use. Integrating technology into care can slightly reduce hypoglycemic-related complications. The management of hypoglycemia needs to be tailored in certain clinical situations. In elderly patients, avoid strict glucose targets and educate caregivers to monitor for subtle presentations like confusion or falls. In pregnancy, lower glucose thresholds are needed to protect fetal glucose supply. Alcohol-induced hypoglycemia. Always administer IV glucose plus thiamine and avoid insulin. Critically ill patients follow standard hospital protocols and consider the use of continuous glucose monitoring in high-risk settings. Complications of hypoglycemia. This can be divided into acute and chronic complications. For acute complications, you have seizures, loss of consciousness or coma, focal neurological deficits, which can be mixed stroke, cardiac arrhythmias due to catecholamine surges, and sudden cardiac death, particularly in young individuals with type 1 diabetes. This is a phenomenon sometimes referred to as the dead in bed syndrome. For chronic complications, you have cognitive impairments, especially in children and the elderly patients. Then hypoglycemia-associated autonomic failure, which increases the risk of future severe episodes of hypoglycemia. Increased cardiovascular rates due to repeated catecholamine surges, predisposing patients to myocardial infarction or arrhythmias. Recent advances and future direction. Significant progress has been made in monitoring and management of hypoglycemia. One is the continuous glucose monitoring. This provides real-time data and predictive alerts to prevent severe episodes of hypoglycemia. Then we have the automated insulin delivery system, often called the artificial pancreas. This helps to adjust insulin dosing dynamically. Then we have the nasal glucagon formulations. These are available and they are fast and they are user-friendly. Smart insulin pens and ultra-long-acting insulins. These actually help in reducing hypoglycemia risk. Then the sensor augmented insulin pumps and the smartphone integrated glucose monitoring. They allow for remote tracking and instant alerts. Then precision medicine and AI-driven hypoglycemia prediction tool are also part of the advances in managing hypoglycemia. In continuation, you have the dual hormone insulin pump. This delivers both insulin and glucagon for more stable glucose control. Then the stem cell derived beta cell therapies. This is currently under trials, and the aim is to restore endogenous insulin secretion. Neuroprotective strategies are being explored also to minimize brain injury during severe hypoglycemia. Cellular transplantation therapies, including islet cell transplants. These hold promise for patients with brittle diabetes. So these advances represent a shift towards personalized technology-driven diabetes management. To conclude, hypoglycemia is a medical emergency. Rapid recognition and treatment save lives. Always remember Whipple's triad when making the diagnosis of hypoglycemia. Differentiate between diabetic and non-diabetic causes, as well as insulin-dependent and non-insulin-dependent causes of hypoglycemia. Patient education and personalized management plan are central to prevention. Leverage modern technology like continuous glucose monitoring, artificial pancreas system, and predictive alert for safer care. Future therapies include stem cell transplantation and AI-driven prediction tools. They hold great promise. Thank you for joining me on this lecture about hypoglycemia here on ClinMed Compass. I hope this session has deepened your understanding of its causes, diagnosis, and management. If you found this helpful, please don't forget to subscribe to ClinMed Compass and hit the notification bell so you never miss new lectures in internal medicine. Check out recommended videos on your screen for more high-yield academic content, and share this lecture with your colleagues and classmates who may benefit from it. Together, let's continue learning and advancing in medicine. See you in the next lecture. Goodbye.